Dr. Kate Nakamai served as a chemistry professor for 40 years at Gonzaga, served as Dr. Mary Kamb's thesis advisor, and served you by building a community that transcends time. It is a privilege and honor to witness the lasting relationship built so many years ago. And with that, I would like to hand it off to Kay, so he has an opportunity to speak about Mary.
Thank you, Matt. I would like to start off with a brief historical perspective that fits Mary into the whole scheme of the Gonzaga community. So in the early to mid 70s, Gonzaga University was a very small place. The biology department had 4 faculty members and no support crew. The chemistry department similarly had 4 faculty members. However, by some quirk of fate or perhaps alignment of planets, karma, there were 3 years there, including the group that Mary Kamb came in on, who became science majors. And these were a group of bright, ambitious, hardworking students. They bonded together in a very tight-knit group. And on one hand, were very supportive of each other, and on the other, very competitive. They really drove themselves to become very high achievers. And they really elevated the sciences, both in terms of expectations and in terms of what we might expect for the future of our students. These people went on and were accepted into excellent and outstanding graduate programs in science, medicine particularly, and dentistry. And they really flourished in these programs, partly because, of course, they were outstanding problem solvers, but also because of their liberal arts education. They were extremely good communicators. They could listen, they understood what was being said, and they could communicate verbally very articulately. They flourished in these graduate programs, and because of that, Gonzaga gained a much better reputation. And they opened doors, paved the way for future students. So they not only elevated what happened within the school, but they really elevated where people could go upon graduation. So current students owe them a real debt of gratitude. The science department similarly would be very happy to see they were rewarded for all they accomplished. So amongst this group, there was this cheerful, optimistic, but very strong-willed young woman. Her name was Mary Kamb. She was just as successful, if not more successful than all of these people. And she has led a very impressive lifetime of achievements, and her accomplishments are probably much too numerous to list here. I'm sure we could supply you with her CV and you would be similarly impressed. For a short take though, let me give you a short list. Doctor of Medicine, University of Washington, internship and residency at Brigham and Williams Hospital in Boston, Massachusetts, National Institute of Cancer Fellowship to study at the Fred Hutchinson Cancer Research Center and the University of Washington School of Public Health. That led to an invitation for a 2-year service at the CDC in the Epidemiology Intelligence Service. So what do I take when I look at this list? I see Mary Kamb making absolutely wonderful opportunities and taking advantage of them to grow skills, challenge her intellect, and really expand her horizons. What else do I see? If you look at this list, we're looking at world-class institutions, really the gold standard in many cases. These people don't invite just anyone to participate in their institutions. So if we look at the possibilities, Mary might have been an FOB. For those of you old enough, you'd understand that as Friends of Bill Gates. Or she might have been an exceptionally talented person who they really wanted to accept into their programs. I suspect it's the latter, but she might be a friend of Bill's. I really don't know. Anyway, I'll try not to give you any alternative facts here. I think Mary found her way, that's my opinion, at the CDC. She found a way to have a much greater impact on the health and welfare of mothers, children, particularly underserved areas and underdeveloped countries. And with her work there, she became really a global authority on many infectious diseases. And she used that globally, actually, to influence a number of programs. And all of this, of course, led to her current positions, where she is the leader, I think, of the epidemiology research team. Their mandate is to study neglected infectious diseases. And all this time, she didn't neglect her own public health community. She taught many courses at a number of institutions. She mentored a large number of public health professionals and managed to somehow adopt and raise a beautiful daughter. So I'll turn this over to her. She'll turn off her cat screen filter. She'll also take off her Wonder Woman outfit and enlighten us with her talk today.
Well, wow, that's such an amazing introduction. Thank you. I'm sure it isn't quite as cool as that, but Gonzaga was wonderful. It's really a privilege to be back here. And Dr. Nakamaya wasn't just my thesis advisor; he was actually my faculty advisor when I first came in as a freshman, and very inspirational to me and to really all of us in our class. So it's so great to have an opportunity to reconnect, Dr. Nakamaya. So I'm going to be talking to you about public health disease elimination programs, and I'm not specifically talking about COVID-19, but gosh, COVID has really affected every aspect of our life these years. And there are things about this talk that probably are relevant to our pandemic. So you may have some questions at the end and we can discuss them together. I'm not sure I have any answers, but it's been an interesting year, hasn't it? So I thought I'd start out just with a couple, since you are a wonderful liberal arts college and probably have classics background, I wanted to start out with two symbols of medicine and public health. And at the top is a bust of Hygeia, the Greek goddess of health. And her name is the root of our word for hygiene. And Hygeia was the daughter of Asclepius, who you might remember as in Greek mythology was the god of medicine and healing. And he's represented by this symbol called the rod of Asclepius, a snake entwined, staff. That's our symbol today for the medical profession. But these are interesting for a couple reasons. So one reason is those snakes on the rod of Asclepius many people think they're not snakes, but guinea worm, which was a common infection in the ancient world. And it was treated by wrapping the worm as it emerged around a stick in order to help draw it out. So even today, there isn't any effective drug or vaccine against guinea worm. And so it's still treated today the same way it was in the ancient world as the worm emerges, which is usually from the lower extremity. It's wrapped around a stick to help draw it out. And guinea worm disease is one of the eradication programs I'll talk a little bit about, and it might even be the next disease eradicated after smallpox. We'll see how it works. So this is CDC where I work now. It's in Atlanta. It's the nation's public health agency and kind of akin to the Ministry of Health that we have in other countries. But this is a bust of Hygeia at the entrance of CDC, which I've always really appreciated this bust. And so I was surprised on my very first visit to the World Health Organization headquarters in Geneva to see an identical bust of Hygeia at the entrance to WHO. And I couldn't find a picture showing you this, but this is the entrance of WHO. And in that, where that red arrow is a statuary garden in front of WHO. And that's where Hygeia sits. And then I learned from my WHO colleagues that CDC's twin bust was actually a gift from WHO to CDC to recognize the collaboration the two agencies had during smallpox eradication. So WHO and CDC really have a long and very close collaborative history. So I think of Hygeia now as a symbol of effective global partnerships. And we'll see at talking through here that these partnerships are really the backbone of successful elimination and eradication programs. And the other thing, if you look closely at the WHO logo at the top corner, you can see a guinea worm twisting around a staff in their logo. So I'm going to start by talking about smallpox. And this is the first disease that was ever eradicated. In fact, it's the only human disease eradicated. So smallpox was really devastating. It's the most deadly disease in recorded history, and it killed 300 to 500 million people just in the 20th century. So until it was the last case was in 1977. But it's estimated to have killed more than 3 billion people during the course of human history, 3 billion people. And it also played pretty major havoc with our global politics and history. For example, smallpox decimated several entire societies. And what I just learned about is the ancient Hittite empire was decimated by smallpox. And here in the United States, the Blackfoot Nation, many populations of Pacific Islands, like if you've ever read the novel Hawaii, it's about smallpox. And it's historically affected the outcome of the Napoleonic Wars in Europe. And even here in our American Revolutionary War, the fact that Canada is a separate nation and not part of a much larger United States may be primarily due to smallpox outbreaks in Washington's army in the Battle of Quebec. So smallpox is a virus that spread through respiratory droplets, and it affected all countries of the world. It affected rich people and poor people. It was really a very frightening disease. And these are some old pictures that show how the disease manifested. People developed very high fevers and terrible body aches and crops of these pustules, really hundreds of lesions all over their body. It was very painful. These lesions bled pretty easily. It really hurt to move. And according to reports, there was terrible stench in the room from the blood, and people ended up being quarantined alone away from their families. So about 30% of the people overall who got smallpox would die, and 60% of children. It's a very, very devastating disease. The people who survived were left with terrible scars all over their faces, and it was very stigmatizing. So the first vaccine against smallpox was developed in 1796, so just after our Revolutionary War, and it was developed by an English physician whose name was Edward Jenner, and he noticed that milkmaids had very clear complexion, and milkmaids had often been infected with a similar milder pox virus that was called vaccinia or cowpox. So Jenner experimented with injecting people with bits of vaccine lesions, and he found that people were protected against smallpox. And that was the world's first vaccine. And in fact, the word vaccine comes from vaccinia or cowpox. And vacca actually is the Latin word for cow. So this vaccine was really a game changer, and it was taken up all over the world. So in 1977, the world eradicated smallpox, and the last wild case again was in Somalia. And this is really a huge medical and public health achievement, and saved millions of lives and possibly 1 billion lives. But eradication really didn't happen by chance. It really required a coordinated global effort led by WHO, including many partners around the world, including CDC. And it took 11 years, which at the time was felt to be a very long period of time and now seems, impossibly short. But it required a big vision and a plan and a coalition of partners and lots of hard work in the field by many people. So I wanted to show you this picture of Dr. Bill Foege. So Bill Foege is a CDC epidemiologist, retired, who spent the early part of his career working with WHO on smallpox, both in Nigeria and later India. And he was kind of the brains behind some of the effective strategies that were used. And he later became a director at CDC, pretty legendary director, and really is considered, there are many giants of smallpox, but Bill Foege is certainly one of them. And he's written a very interesting book recently about smallpox that, for those of you interested, it's a great read. It's very compelling. But an interesting thing about Bill Foege is he is a Washington State resident. He grew up in Colville, Washington. He's standing here in Colville, just outside the place where he grew up. And he went on to go to PLU, Pacific Lutheran University, and then the University of Washington Medical School before he came to CDC as an EIS officer. And he's still on faculty there at the University of Washington School of Global Health. He's a great speaker if you ever get a chance to get him. So he wrote a book called House on Fire and described some of the strategies that were used in smallpox. And one was a really coordinated surveillance, which means case detection. And smallpox tends to be symptomatic, but early on it can be asymptomatic. But communities were asked to please report, or even if they're just rumors, report diseases so that they could do containment. And in this containment effort, it involved contact tracing, sort of like what we're doing today. But so at its base, contact tracing is really finding a case and then kind of metaphorically casting a wide net, a net that's wide enough to find all the people who may have been exposed to the case, and then containing them by quarantining if they're exposed or isolating if they're sick, and then vaccinating all the surrounding community. And this strategy was quite effective for smallpox and kind of changed the way that we think about disease control. And one thing that Bill Foege always says is that we can't be content with just implementing the strategies we have. We have to think constantly about how to improve them, what went wrong and what could have been better. And that's the way that we can, do a better job the next time. So he's really talking about operational research. So with the success of smallpox, people started to ask, might it be possible to eradicate other diseases? And what really are we talking about when we talk about disease control? And so they started to kind of define different types of control. And at the most basic level, define disease control as keeping new infections to a low level in the population through prevention strategies, some type of intervention. So we're doing something to control diseases. And an example of this might be STDs in the United States. We've always got STDs, but we're trying to control them and keep them at some low level. And then at a more intense level, we can achieve elimination as a public health problem. And that really requires control that's sufficient enough that the disease is no longer a major threat. We might think about childhood diseases, vaccine preventable diseases in the United States, like measles. We've kind of eliminated it as a public health problem, although it still kind of occasionally will pop up. And with even more intense control, we can achieve elimination of transmission, and that's really interruption of transmission. And that's reduction to zero of an organism in a limited geographic area. And it means there's no new cases unless they're reintroduced from somewhere else. This is really hard to achieve, but it can be done. And an example is malaria in the United States, although we sometimes have malaria introduced. And since we have the vector, the Anopheles mosquitoes, we need to intensely follow up and stamp them out. But malaria really no longer exists in the United States because the parasite isn't prevalent in the mosquitoes. And another example is polio. Here in the Americas region, we've eliminated polio. And then at the most intense level, we can achieve eradication or global elimination. And that's permanent reduction of a microorganism to zero on a global level. And at that point, no further interventions are required because the disease can't be introduced from another country. So eradication is, of course, the holy grail, but it's really difficult. And in fact, we've only achieved it once with smallpox. So with smallpox, people also started to think about the factors that might help promote eradication. What are the lessons that we learned? And first, one factor that would be needed is it would need to be an important disease that caused some kind of serious disability or death, because the world really wouldn't want to do that kind of full court press on something that wasn't, super serious. And second, we need to have an effective and very practical intervention, and it would have to be something every country in the world could carry out. So reasonably simple and affordable. And eradication would need to be biologically plausible, ideally with no non-human host. There was an attempt earlier to eradicate yellow fever, and it failed because there were non-human primates that harbored disease. So it wasn't possible to really eradicate. And it should be an organism that can't multiply in the environment. So some parasites can live in the soil for a long time, so they wouldn't be good candidates. And also it should be a disease with a reasonably short incubation time. So that's the time from exposure to development symptoms. It would be really hard to eliminate diseases with long incubation times, like HIV or viral hepatitis or something. And then another factor is it would need to be able to be surveilled, or have surveillance would need to be possible, and that's case detection. And so the ideal disease for eradication really has visible symptoms or signs like smallpox. Or if it's asymptomatic, we would need to have the tools like laboratory tests that could detect infections. And the tools would have to be simple enough and cheap enough that we could carry them to field settings and do them anywhere. And since we're talking about a global effort, we need political will and commitment, of course. And partnerships are really important, and funding is critical. It would be really hard to carry out eradication of a disease without sufficient funding that stays over time. So eradication might be possible for a disease that didn't have all of these factors, but it would be a lot harder. So, and then there were some philosophical considerations, a lot of discussion. People asked, if we could potentially eradicate a disease, why wouldn't we? If it's sufficiently deadly and we have the tools, wouldn't the moral imperative demand that we try to eradicate? Wouldn't it be unethical not to try? And other people brought up reasons not to eradicate. Smallpox worked, but it required very poor countries to focus almost exclusively on that disease. And it distorted health systems and priorities. And some people even may have died of preventable conditions because the healthcare workers were called into smallpox. So the picture in the corner points out that as we go further along in eradication, it becomes more and more expensive to catch every case. So the blue line is prevalence, or number of disease cases. As that declines over time with years on the bottom, the green line is the cost per case detected, and the cost per case detected goes higher and higher and higher. So as we're close to achieving eradication, that last mile is really, really expensive. And public health isn't well funded. So eradication efforts could take up a lot of the funding and would really limit resources needed for other diseases. And there was also concern about failure. With regional elimination, we still need continued surveillance, which is costly and hard to justify since there's very little disease. But if one country continues to have disease, even one case, then all countries and people are at risk, because with rapid transit and planes and everything, infections can be reintroduced to a disease-free region. And we have some good examples of this with polio. So the world tried several eradication efforts, and only smallpox has been successful so far. It started in 1966 and it was achieved in 1977. And I'm going to tell you about two other eradication efforts and a couple elimination programs that have been started and what we've learned from them. And those are guinea worm eradication, which started in 1980, and then polio eradication, river blindness elimination, and elephantiasis elimination. And all of these campaigns have taken quite a bit longer than expected for various reasons that we can talk about. And I should say this is an exhaustive list of diseases that are under consideration for eradication or elimination, but there are some others, but these ones have some particular lessons. So first, guinea worm. In 1986, guinea worm was estimated to affect about 3.5 million people annually, and just in these 21 countries in red. So WHO estimated that in these countries there were more than 120 million people at risk for developing guinea worm. And this is a fairly discrete distribution because guinea worm doesn't exist where there's safe water. So it affected in 1986 several countries in the Indian subcontinent and several in sub-Saharan Africa, and then also Yemen on the Arabian Peninsula. So before eradication started, there was a very intensive global effort to carefully map out where guinea worm was occurring and where it did not, so the focus would be on the right countries. And the program was led by WHO and with several partners, and the longest and most important have been the Carter Center and CDC. And some of you have read about Jimmy Carter's enormous commitment to guinea worm. He's really put a lot into it. So guinea worm is caused by a parasite that's called Dracunculus medinensis, and people get it by drinking contaminated water that has a larval form of the Dracunculiasis. So in this picture, what you see, the yellow picture, it's a copepod or a water flea, and it has guinea worm larvae in it. And this is a really tiny flea. You can hardly see it with the naked eye. It lives in water, usually standing water or marshy edges of slow flowing rivers. And the life cycle next to the picture, it's too small to see well, but the point is that parasitic infections like guinea worm are a cycle that involves a human host and a vector. And in this case, the vector is the water flea. So the cycle starts when a person infected with guinea worm steps into the water, and the guinea worm lays eggs and it contaminates the water. And then the eggs are eaten up by the water fleas. And people who drink the water end up ingesting these tiny fleas that contain the guinea worm larva. And that keeps the life cycle going. So eradication requires breaking or interrupting the parasitic life cycle. So once inside the human host, it takes about 12 months for a worm to mature. And then this is a really long worm. It's about 2 or 3 feet long, and it emerges very slowly from the person who's infected. And it can come out anywhere on the body, but like this child's scalp here, but usually it comes out of the ankles or legs. Very painful when it emerges. And in fact, it's so painful, there's a burning sensation that people can seek relief from by going to put their legs in water, which of course continues the life cycle. So guinea worm disease is a problem because it really incapacitates people for long, long periods of time while that worm is coming out. And it makes them unable to care for themselves or to work if they're adults, or to grow food for their families if they're farmers, or if they're children, they can't attend schools. And so it's a really problematic disease, and there is no effective drug to treat it or vaccine to prevent it. So I mentioned that there's no drug or vaccine, but there are these effective interventions. But they need to be used together. So there are 5 prevention strategies that the eradication program rests on, and all of them are simple interventions that people in any village could do if they were trained and organized. So the first is surveillance, that case detection, and that's identifying and counting all the cases so to know which villages are likely to be exposed. So people need to be educated that if they hear about a case of guinea worm, to report it. Second is case containment, and that means that once someone with guinea worm is identified, making sure that person doesn't walk in and contaminate the water, so that interrupts the life cycle. And then there's provision of safe drinking water. And this worm actually wouldn't exist if people had safe drinking water, but there isn't always safe water available. So the program developed this filter, and up in the corner you can see a little boy who looks like he's got a whistle. That's actually a water filter, and that allows him to use the local water sources and not be exposed to guinea worm larvae. So the fourth method is vector control, and there are some chemicals that can be used in the water to kill the water fleas. That would interrupt the guinea worm life cycle. And then finally, health education and community mobilization, which is training public health staff and community members about the disease and how to prevent it and how to control it and report cases and contain them. So each of these is a really important strategy, and each of these has to be in place for effective eradication to take place. So here's a boy who's using a filtration tube to drink water, and the filter is actually inside the tube, and it's a fine enough filter that the copepod, that water flea that contains the guinea worm, can't get through. And here are some of the ways that communities kind of get the word out about guinea worm. Educating children is really important, and these kids are reading comic books about guinea worm and how to prevent it. And a lot of these villages don't have electricity or access to computers, so these comic books are really important. And on the right, you see a training course. The villagers are learning about guinea worm prevention strategies using these flip charts, which is a pretty simple training tool, but it works everywhere. So the world hoped to eradicate guinea worm by 2000, but we haven't achieved it. But there has been great progress. Last year, there were just 28 cases in the world, 28 human cases. And that's pretty amazing from 350 million, back in 1986. All the endemic countries outside of Africa have already eliminated guinea worm. And in Africa, the last year, the cases were only in 4 countries, the ones in red here. And these are Mali on the left, and Chad, South Sudan, and Ethiopia. And most of the cases were in Chad. So all the difficulties, all of these countries are suffering from political unrest, which makes it difficult. It's hard for programs sometimes to collect data and do the surveillance necessary. And there also have been some major setbacks, a couple big setbacks, and they're pretty interesting setbacks. So in 2013, it was realized that guinea worm was occurring in dogs in Chad, and then in some baboon families in Ethiopia. And remember how one of those ideal elements of eradication is that there's no non-human cases or non-human hosts. And it was assumed that, when it was started, the guinea worm only occurred in humans, but now we're realizing that it can occur in other animals who drink water contaminated by infected humans. So this has been a huge challenge because an infected human can be counseled, not to contaminate water sources, but it's a lot more difficult to contain other animals. Even domestic dogs, it's hard to contain them, and baboons are wild creatures, how to contain them. So the program has had to come up with some different strategies. And it turned out, fortunately, that only a few of the families or populations of baboons were affected. And they were able to be caged and for short periods of time until the guinea worm came out. And so disease may already be eliminated in baboons in Ethiopia. But dogs have been more problematic. There's progress, but it's been a slow slog, and they're mostly in Chad. There are now hundreds of guinea worm cases in dogs every year in Chad. And then in 2019, the program had another big challenge, which was that an 11-year-old girl in Angola who had never been outside Angola, never even been outside her rural province, was found to have a guinea worm, and it was a real guinea worm. And the big concern was that Angola was not one of those endemic countries, the countries that originally had cases. So Angola is the red star on the map. And so this means that the original mapping may not have been complete. And we'll need to make sure that there aren't other African countries that were not originally believed to have guinea worm that don't, we have to make sure that we are effectively looking at all the endemic countries. So even though we haven't completely eradicated guinea worm, it's close, and we've learned some important lessons. First, it's possible to eradicate a disease with really simple interventions. It doesn't require vaccine or drug. And we've learned that mapping is critically important so that we can focus on all the countries affected. And then it may be possible, we'll see, to eradicate a disease that has non-human hosts, but it really complicates things. And here in this picture, there's a boy who's containing 2 dogs that have guinea worm, and ensuring that they don't expose water sources. And again, the partnerships are really critical. The progress that's been made, it has been very dependent on dedicated partners like the Carter Center. So the next thing I wanted to talk about was global polio eradication, which was started in 1988. And guinea worm had only a few countries affected, and polio was really everywhere. So that made it more difficult. And it required really a multi-country effort that has been led by WHO and UNICEF and the Rotary Foundation. Rotary is an interesting partner. It's an international community organization that really exists everywhere. I mean, I kind of thought it was mostly, in the United States, but it is virtually in every country. And more recently, the Bill and Melinda Gates Foundation have also supported polio eradication. And by the way, Dr. Nakamaya, I don't know Bill Gates, but I hope to meet him someday. But the initial hope was they've been a wonderful partner in many programs. So the initial hope with polio was to eliminate or to eradicate by 2000, and this hasn't happened. So we'll talk about that, but first a little about the virus. Very ancient disease. There are depictions in Egyptian art 1,000 years before Christ of people with polio. Here in this stele, there's a man with a wasted leg. And it's a pretty vicious virus. It attacks the nervous system and can cause permanent paralysis and deformity and death occasionally. And especially in populations that are susceptible, that haven't seen the virus before. So the children in the bottom have different types of disability related to polio. And it's fairly contagious. This virus is an enteric virus, and so it's spread fecal orally. It's mainly spread through hands or food or water that's contaminated with feces or poop when people don't wash their hands properly. And there's no effective drug treatment or no cure. But there are 2 vaccines. The first one developed was the inactivated polio vaccine. It's a shot called IPV. And the second one was developed as an oral polio vaccine, or OPV, and that just requires 2 drops in the mouth. So polio can be fatal, especially in acute disease. It paralyzes the respiratory muscles, and you may have heard from your grandparents about huge polio outbreaks that happened in the United States in the 1950s. And this is old pictures of these iron lungs, which are negative pressure respirators that were used here during the really large outbreaks. It mostly affected children in the United States, but it also affected adults. The US President Franklin Roosevelt, in fact, had polio. So the outbreaks in the United States were important because they kind of fast-tracked the development of vaccines in the 1950s. And then there were these massive vaccination campaigns that happened here in the United States, mostly in schools. And that was where the March of Dimes got started. It initially was supporting mass polio vaccination. So mass vaccination, we're learning, is difficult. We can see that today. But imagine doing this in a low-income setting. You need trained healthcare workers. For if it's a shot, you need sterile needles and sterile syringes. You need refrigeration to maintain the cold chain. And that's really difficult in places where electricity is poor and there's power outages and stuff. So for polio eradication, the fact that there was an oral vaccine really simplified things. We didn't need to have, trained doctors and nurses and pull them from other programs, but we still needed to have an intact cold chain, reliable refrigerators. And that was really tough. And then there was an interesting technical breakthrough that we still use, and that was development of these vaccine vial monitors, or VVM. So the top of the vaccine vial includes a heat-sensitive material that it changes color when the vial is exposed to heat over time. So seeing the top of the vaccine vial can alert people whether the cold chain was broken. And finally, programs are able to tell if the vaccine in that vial is still effective. So there has been pretty great progress in polio eradication. And in fact, it is eliminated in most of the world. The United States eliminated it in 1979. And since then, it's been eliminated in 5 of the big regions of the world: the Americas, Europe, Southeast Asia, Western Pacific region, and just recently Africa. They've all eliminated program. Last year, Nigeria was the final country in Africa to eliminate. So this map is a little out of date because Nigeria just eliminated last year. So today there are only 2 countries that still have wild polio, and those are Pakistan and Afghanistan. So the good news in polio has that eliminating it in most of the world has prevented millions of people. They think about 17 or 18 million people who would have been infected and, possibly paralyzed or worse. And the programs also help strengthen some of the other vaccine programs for childhood preventable diseases like measles and rubella. But the bad news is it's been really costly, and there are several complications that are quite controversial. So we talked about that problem that if one country has disease, all countries are at risk. And so countries need to be vigilant and keep vaccinating, even though they've eliminated. And when countries eliminate polio, they use the oral polio vaccine, which is pretty easy and it's relatively cheap. But after a country achieves elimination, they have to keep vaccinating. And when prevalence is very low, the oral polio vaccine it carries a risk because it's attenuated. It's not a killed vaccine, it's attenuated. And that means some people, especially people who have some underlying health condition, some immune depression, can develop polio. So the IPV, the inactivated polio vaccine, is a lot safer, but it's a shot and it's really expensive. So in most of the wealthier nations are using IPV, but a lot of the poorer nations, like in Africa, are using OPV and having wild polio outbreaks related to the oral polio vaccine. And it's also a really complicated message to give to parents. Why do my children need to be vaccinated if there are no cases? So it's been pretty difficult. So the last two programs I wanted to touch on briefly were for two parasites, and these are considered neglected tropical diseases, or NTDs. So this is a diverse group of diseases that occurs mostly in very poor countries, and it's usually in marginalized populations, rural populations. These are really diseases of poverty, but they affect more than a billion people. So for some NTDs, the most effective intervention is what is called preventive chemotherapy, and that means giving antiparasitic drugs once or twice a year in a mass drug administration campaign, or an MDA. And these are community-based campaigns, and they happen once a year, and they involve the entire community. And everyone's asked to swallow a pill. And these are pretty safe pills. You just take them once a year. So the MDA campaigns can be either door-to-door. The program staff can go to each household, or they can be based at fixed post, and then everyone's asked to go to a certain place, a location, and pick the medicines up and take them. So I'm going to show you about two filarial worms, and they are each carried by different vectors. So when an insect carries a parasite and bites a human, the larvae are transmitted to the human, and they go on to grow into mature worms. And then those worms emit a second stage larva, and that second stage larva is usually the thing that causes problems. And this is, we need to really interrupt that life cycle in order to get rid of the disease. So the first disease is lymphatic filariasis, which causes elephantiasis, and it's a leading cause of disability in the poor countries. So this picture shows how it can be very disabling. So once the worms mature inside a human host, they travel to the lymphatic system, and they live in the nests and eventually cause the lymphatic vessels to dilate and break down, and that leads to this edema. And it can be manifested like this very swollen leg. Usually it's only one leg, called elephantiasis. And in men, it can also cause a really severe edema in the scrotum, which causes hydrocele, a very swollen, enlarged scrotal sac that's very debilitating. So the worms are spread by mosquitoes, various species of mosquitoes, depending on the country and the setting. And the infections can be cured with antiparasitic drugs. But for people who aren't treated early enough and have maintained the worm for many years, once they develop the chronic edema, then it's pretty irreversible. So this is what these worms look like under a microscope, magnified hundreds of times, but they live in these nests in the lymphatic vessels. And based on mapping studies, WHO estimated that in 2000, just under 900 million people were at risk for lymphatic filariasis in about 72 countries. So the other filarial worm that's under elimination is Onchocerciasis. It's a leading cause of blindness, and it's caused by another worm called Onchocerciasis. And it's spread by repeated bites with a certain kind of black sandfly. So the Onchocerca larvae cause the second stage larvae cause a really intense inflammatory reaction in the humans, and people develop itchy skin lesions, and then some develop an inflammation of the cornea of their eye, which causes clouding, like this woman has, and eventually it leads to loss of vision, blindness. So, like LF, this infection can be eliminated pretty early with antiparasitic drugs, but once people develop a chronic condition like blindness, it's not reversible. So the drug that's used to treat onchocerciasis is called ivermectin or Mectizan, and prevention, just like lymphatic filariasis, it's done in mass drug administration campaigns, MDA. But for onco, it can take quite a few years, more years than lymphatic filariasis. So this is what Mectizan looks like. It's easy to take. You take it once a year, in some communities with high prevalence, twice a year, and it's very safe. And these drugs have been provided to communities free of charge through a donation from some of the large pharmaceutical companies. Merck actually makes Mectizan. And without these partnerships with big pharma, these NTD elimination programs wouldn't be able to exist. The picture here is a child leading his blind grandfather in a village in Africa. And this is still fairly common to see in rural villages that have onchocerciasis. So onchocerciasis is endemic in 37 countries, and all in Africa or the Americas, and about 200 million people are at risk for infection. So it's a little more defined in the smaller area of the world than lymphatic filariasis. So these two programs are going on now, and they are applying some of the lessons that were learned in the previous eradication campaigns. So they were able to adapt really some of the techniques used, like micro-planning. So these is careful planning with communities and mapping out where the intervention should go and would be most effective. This is a picture of a fixed MDA post, and it's really important where to place these posts to make sure people have access to them. So micro-planning was something that was done for mass vaccination programs, and now it's done for NTD programs. And they also adapted the surveys that they use measuring impact. So the smallpox and polio programs developed surveillance strategies that could estimate vaccine coverage by just representative samples of community members. They didn't have to evaluate the entire community. And NTD programs have been able to use these. It's a statistical approach, really. And they've been able to use the same technique to estimate coverage of mass drug administration. And we've talked several times about the importance of strong partnerships, even private partners like Big Pharma. And another lesson is how to maintain focus. LF and Onco have had difficulties because they're not viewed as important as some of the other issues countries are dealing with, like malaria. So it has been difficult to maintain focus during political unrest or with other competing health issues. Like DRC is having Ebola outbreaks right now, so their NTD programs are not working well. This past year, with COVID-19, all countries have stopped their MDA programs because of concerns about safety, both for the staff conducting the programs and for the community. So we'll need to figure out how to reestablish those elimination programs once we get through this. So I thought I'd end on this thought. When I was back a long time ago, when I was a student at Gonzaga, we celebrated the bicentennial, and it was a big deal. And famous people were interviewed about what they thought the greatest gift the United States had given the world in the past 200 years. And one person they interviewed was this man, whose name is Norman Cousins, and he was a political journalist, and he was editor of the Saturday Review, which was, it's now defunct, but it was a magazine then that every family got. He was very famous at the time. And he said he thought the greatest gift that the United States had given the world is demonstration that it's possible to plan for a rational future. And he was really talking about democracy, our American experiment. But I think that this is interesting because it applies to public health. So he was known to be this incredible optimist. One of the books he wrote was called Anatomy of an Illness, and it's still used today in med school. It describes how he used laughter to help him deal with a really serious disease. But I wanted to end with his idea, because I think public health is an optimistic field, because at its base, it really maintains this idea that we as a community can exert some kind of control over disease and even eradicate diseases through careful planning and surveillance and measuring and evaluating and implementing interventions, which could be as simple as safe drinking water or as complicated as a vaccine. So if it's possible that if we plan appropriately, we can change the world. So I have a couple references for consideration, but anyway, that's it. Thanks.
Thank you everyone for your time and attention. So if you
Thank
feel
you
like,
all.
yeah,
Thanks,
Thank
Mary.
you.
thank you.
Thank you guys. It's really fun to be here. It's a privilege. Thank you.